I would like to welcome everyone to this fireside chat today. And because Dr. Lloyd has already introduced us, I would just like to welcome Dr. Marine, who's our Country Medical Director, Kenya, AHN. She'll be chairing the session today. Welcome, Dr. Marine.
Thank you very much, David. And Professor Swarnalatha, on behalf of the Africa Healthcare Network, we'd like to welcome you to the 100th Fireside Chat discussion that we're having. It's a privilege to have you here. For those of you who are joining us, Professor Swarnalatha is the Unit Head, Department of Nephrology, NIMS. She's a distinguished nephrologist who's won the Best Paper Award at several conferences of nephrology. She has authored several studies. She's the associate editor. She's the editor of Hemodialysis Manual 2017, the editor of the Manual for Transplant Coordinators. She has been reviewing several journals, and she has over 80 publications to her name in national and international journals in chronic kidney disease, renal transplantation, peritoneal dialysis, and hemodialysis. She's also the winner of the Best Paper Award for the World Congress of Nephrology in 2013. And with so many such awards, we're really honored to have her join us today, especially for this 100th Fireside Chat discussion. So without taking up more time, Professor Swarnalatha, welcome, and I'll hand it over to you now.
Yeah, thank you, Mehreen, for such a nice introduction. And I would like to thank the African Nephrology Networking and Dr. Lloyd for giving me the opportunity to present to you the Disease Donor Transplantation Program, the journey, how it evolved in our state. So without much ado, I would like to first share my slides. Good evening, all of you. I bring greetings from India, and I welcome you all. Are my slides moving?
Not yet. The first slide is there. Yeah, no, moving. Yes.
Okay, good. So I bring greetings from Hyderabad. So I come from the southern part of the India, that's Hyderabad. This is a Charminar. It's actually an icon of this Hyderabad. So today I'll be presenting a program called Jeevandan. It's a disease donor transplantation program of Government of Telengana. So Hyderabad is the state of Telengana, like Telengana, and it is a certain part of the India. And as you all know, I'm sure you might be having several stories in mythologically before going to the modern part of the science, where we talk about the organ transplantation. I just want to take you to the mythological stories of India, which are very famous. And I think most of you might be knowing about this Lord Ganesha. He's one of the god where we offer our initial offerings during any of the festivals or any of the auspicious things we start with. So it is actually a classical example of the organ transplantation, much beyond what is called as a xenotransplantation, which we are now trying to achieve the xenotransplantation. Recently, we have heard in the newspapers last year that we have achieved genetically engineered pig kidney being transplanted to the human being. So in our Indian mythology, so it's been a story of lakhs of years before. So you can see the head of the elephant. It's being transplanted to a human being. Rather the god. And you can also look at the physical changes, which very much shows that he actually has used immunosuppression medications, whatever the central obesity we are able to see. And look at the vehicle which this god uses is the mouse, which is actually we use as an experimental animal. So that gives us some evidence that the transplantation does existed in our Indian mythological stories. So another stories I would like to tell from India is the weapon that's called as a Vajrayutham. Ayudham is a weapon in our Sanskrit. So this was actually made of a spine of a great sage called the Dichi. So when there was the fight amongst the god and the demons, the god lost. And the king of the demon was given a boon that he cannot be killed by any of the weapon which existed then. So God went to this sage. He was a very powerful sage, and he has to sacrifice himself to get this weapon being prepared by his spinal the vertebral bodies, and that was a most powerful weapon. And with the help of that weapon, the demons were killed, and then the gods got back their what you call victory. So, and there is another interesting story of a king Chakravarti. So he has sacrificed his muscles to save a dove. So actually, eagle was trying to hunt for this dove, and with the intention to protect the dove, the king gave a muzzles to feed the eagle, so as they can salvage the dove. So, I mean, the essence of all these stories is in our mythology. So we have a lot of stories where we have used the parts of the human body or the human, for the mankind, or for the benefit of the human beings. So I'm sure that there are a lot of stories in your, the culture also, in your mythology also, which would inspire the present generation for the organ donation. And in fact, this is one of the famous shloka, the stanzas from the chapter of the Bhagavad Gita. It is equivalent to that of the Bible in Christianity. So which says, the Gita is said to have solutions for everything. So whatever the challenges or whatever the problems we face in the present world, or the present scenario in the existing world, if you look at this Bhagavad Gita, it is said that it has solutions for everything. And that is also true for the organ donation. When I took this project of organ donation a few years before, I was looking for, some literature or some, the evidence in our mythology or in our ancestral story, so that we can go to the society and tell them and convince them that it's not a modern medicine. It has existed in our very nature for so long. So I got this the shloka. It is very famous shloka that goes like this: Vasamse janayani yatha vihaya navani grahani nanoparani tatha sharinani vihaya jinnani anyani samyati namani dehi. That means we wear clothes, and once it is worn out, we throw it out and go for a new pair of clothes. Similarly, the body and the soul has the same connection. Once the body is worn out, the soul, it just leaves that body and goes into another fresh body. So this is a classical example of regenerating our own body, or what you call as reusing our own body parts. So that's how. So even if you go back to your mythological story or your ancestral story, I'm sure you'll find such stories, so that you can go to a public and go to your own people and seek for this organ donation, convince them for the organ donation. And slowly moving towards the modern medicine, we have few more examples. That is, in India, particularly in 2nd century BC, we could find Dr. Shushruta, who has done transplantation with the autograft of the skin as a rhinoplasty. That was done in the 2nd century BC. And in Chinese population, there is a story that in 310 BC, the heart was exchanged, not for the anatomical failure, but because it has actually strengthened the man. Because as per their story, like their belief, when a weak-hearted man gets a strong heart from a strong personality, his personality changes. So this was the concept behind the organ heart transplantation, and not the physical heart failure. This happened in 310 BC. And this is an example in the 4th century AD in Germany. It's called as a miracle of black leg. So where the two brothers, the Christian brother, who replaced the patient's gangrenous leg with the leg from a recently deceased Ethiopian soldier. As you can see, that black leg is from the Ethiopian soldier. So it was gangrenous, they replaced it. This is another example in 4th century AD Germany. Now coming to the modern medicine now. So, the successful first transplantation of knee was done in 1908. In 1909, we had a first recorded kidney transplantation from animal to human. And in 1936, first human to human transplantation was kidney transplantation attempted. And as we all know, the first successful kidney transplantation was done in 1954 from identical twins. In 1953, first successful surgery was done using a heart-lung bypass machine. In 1963, the first successful lung transplantation was done. In 1967, first successful liver transplantation was done. In 1968, the first heart transplantation was done in US. In 1973, the first bone marrow transplantation was done. In 1998, the first successful hand transplantation was done. Coming to India, the first cadaveric transplantation was done in 1967 in Mumbai. In 1994, the first successful heart transplantation was done at AIIMS, New Delhi. In 1995, the multi-organ transplantation was done at Apollo Hospital, Chennai. In 1998, the first lung transplantation was done again in Chennai. In 1999, the first pancreatic transplantation was done in Ahmedabad. And in coming to Hyderabad, that is Telengana, the first successful deceased donor transplantation was done in 2002. That is about the history in our India. And as you all know, most recently, this is the latest advancement. You all can remember in 2021 October, it was Dr. Robert Montgomery who has done a successful the xenotransplantation from a genetically engineered pig kidney to a human being. Actually, he has transplanted to a brain dead, which worked initially for a few hours. Now, we have two types of the donors. One is the living donor, where we can use the organs from the near relatives. So most of the time it is spouse, son, daughter, father, mother, brother, or sister. Now, as per the Indian Act, it has been expanded to include grandparents and grandchildren as well. The other type of the living donor is through swap, or the otherwise called as a kidney pair donation, where one can exchange. If one family is not suitable, and we have another, uncompatible, non-compatible, the another pair, we can actually exchange in between these two, either the HLA incompatible or the ABO incompatible. We can exchange, and these pairs can actually extend to two pairs, three pairs, and 4 pairs, and so on. That is about the living donor. The next most important source of these organ donors being the deceased donor, or otherwise called as a cadaveric donor. Cadaveric was the previous terminology. Now it is called as a deceased donor. Again, in deceased donor, we have two types of donations. One is donation after brain death, and the second is donation after cardiac death. If you look at the worldwide literature, so most of the time it comes from the Western population, where we see 80% of the donations coming from the deceased donor. As you can see in the graph, we can see in most of the the American part, it is basically the donation rate, deceased donation rate is very high. And the next is the southern part of the America, then the Australia and the Europe. As you can see, India and Africa, the donations is almost negligible. And this is how we try to rate the deceased donations. So it is per million population. You can see highest is in Spain with around 50 per million population. And unfortunately, you look at India, it's very not even one, it is very minuscule. And this is what is the donation requirement, or the people in the waiting list. Around 2 lakhs kidneys are being required per year, and around 50,000 heart transplantation, and around 30,000 of liver patients are waiting in the list for the liver transplant. Particularly India being a developing country, and I think so also in the Africa. So there is a lot of illegal trafficking of the organs. This is because of the gap between the organ requirement and then the availability of the organ. So, and that's how, because of this gap, the poor are being exploited for the organ by the rich in the country. So do we have any rules for this or regulations for this? How to control this illegal trafficking? So coming to India, we have this act in place, and I'm sure even the Africa would have your own the Organ Transplantation Act. It has come first in 1994, the Human Organ Transplantation Act. So I'll not go into the details of the act. It is available on the net. You can just go through. So it has got various chapters which deals with the different aspects. So who can be a donor, and who, how we should give a license to the hospitals, what are the regulatory authorities, and how these hospitals or the individual has to be penalized when they break these rules, and how we can appeal. So these all have been covered in the in this particular act, including the brain death. So how to declare a brain death and how many people can declare the brain. I'll be talking about it in my subsequent slides. So this got amended several times. In my latest amendment was in 2011. So in 2011, I just want to talk about the deceased donor, because now the focus is on deceased donor. So initially, as per the 1994 Act, So there were 4 doctors were required for the declaration. So one would be the expert, that is neurologist or neurosurgeon. The second would be the treating doctor. The third would be the hospital administration. And fourth would be the neutral doctor who is not associated with either the transplantation or the treatment or the administration. So in 2011, there was one amendment made because there were not much availability of neurologist or neurosurgeon every center. They said it need not be always neurologist or neurosurgeon. So any of the medical practitioner who has experience in the declaration of brain death can be involved as a part of the declaration team. It can be intensivist, it can be physician, it can be surgeon who have a experience. And the latest rules. So basically we have the act which gives the broader outlines. Then basing on the act, we frame the rules which gives much more details to how to implement these organ donation. And then we have the government orders, and then we have the guidelines. So in 2014, the organ donation rules were amended. So again, there's several aspects of it, so I'll not go into the details. Basically, this has included the broadening of the live donation, definition of the near relatives in live donations, as I said. So they have expanded the definition of the live donation to include even the grandparents and the grandchildren. Previously, it was only first degree, that was parents, then the siblings, and then the kids. It was expanded to include the grandparents and grandchildren. That was a major amendment. And the second was having the swab kidney transplantation. And third, I said, as the brain death declaration. So they have tried to change the composition, the people who can be in the panel for the brain death declaration. And then they have also tried to expand and try to define more appropriately. So who can be in the advisory committee, who can be in the authorization committee, who look into the basic. And now we see a lot of patients coming from the outside India or other countries for organ transplantation to India. So these regulations also been laid in these 2014 guidelines, and we have different forms for that, right from the 23 forms, like how hospital should apply, how the individual should apply in case of a relative transplantation, live related transplantation, how they should approach the authorization committee for in case of unrelated transplantation, and what is the procedure when the patients are being crossing the borders of the country for the organ transplantation. All these things has been laid in this act. So I'm sure you also have this act available in your country. And if you need any of the amendments, I think you can go through this act. And further, if you require any help in coming up with the GEO, so we can always help. So with these acts and then the rules, as I said, next is the government orders. So again, each of the state, they have come up with own government orders, particularly with respect to the deceased donation. Now that we are talking about the deceased donation, so I would like to restrict my talk only to deceased donation, whatever the GEO which has come up with respect to deceased donation. So Tamil Nadu is one of the other states in the southern part of the India. So they are the first state to come up with some of the GEOs, particularly with respect to brain death declaration. So as you all know, brain death declaration is very dynamic. Brain death is a very dynamic state. So it's very difficult to recognize patients who are brain dead. Within no time, they go into a cardiac arrest. So it's very difficult to identify these patients by the neurologist or by the treating doctor. So that's why they said it is very important for all the hospitals, particularly the government hospital, to declare the brain death. Whenever a neurologist or neurosurgeon he's seeing a patient who is critically ill, is comatose, and if he goes into a brain death state, so it is mandatory on the part of the treating doctor to declare him a brain death. So this is Tamil Nadu who has come up first with such a GEO. Later on, other states also followed. Recently, in 2020, even the Kerala government came up with the same GEO stating that it is they have actually come up with the procedure how to declare a brain death, how the doctor should be present, how to do an apnea test. All these procedures in this GEO, including a statement that it is mandatory on the part of the treating doctor to declare a brain death. And once it is declared brain death, so the counselor should be available in each of the hospitals. They should go and counsel the family members. And if they don't agree, so in fact, because all these are resources, ICU setup, the ventilators are these resources. And India being the country with a very huge population, limited resources, particularly with respect to ICU setup, we can actually disconnect the ventilator from this brain death patient if they're not coming forward for organ donation. In fact, the same was emphasized in the GO released by the Gujarat government as well. They also said patent is mandatory, and once patent is declared, there should be a counselor available in each of the ICU. The counselor should go and counsel the family members, and if they decline to donate the organs, the life-saving, the ventilators, or they can be withdrawn from the patient, and it can be shifted to a patient who is deserving, or where they can be salvaged. So that's how the few of the GOs has come up, and I think you can all people visit together, and you can also come up with a similar GO to help this implementing this program in your country. So it's not uniform, but as I said, organ donation, when you compare to the Western population, is very minuscule. It's not even one. If you look at the India, so in India also, it's only the southern part where it is organ donations, particularly with respect to disease donations are happening. And north, there are a few pockets of areas where the disease donations is happening. So we come from in the southern part, this is the Telengana. So where we come from. So as I said, it is in donation, particularly with respect to disease donation, India is very less. But if you look at the patient's population behavior, this is the latest survey which was done. And the people from India, they were all very much willing for the organ donation. So it is as a healthcare provider, as a policy makers, so it's the responsibility for the doctors, responsibility of the government to come up with the appropriate policies, so that these organs can be appropriately retrieved and then can be used for the patients who require the organ transplantation. So it's not a public behavior, it's not the resistance from the public or society. The organ donation is not happening. So that's how we actually should look at what are the strategies, or what are the the policies which would help establishing a program. So as I said, for the effective implementation of these program or effective organ donations happening, we should have a first and foremost thing is the government participation, because it is the regulatory authority. So we should have a government platform. So government should be a part of this program. The second is the neurologist, neurosurgeon, and intensivist, because most of the time the organ donations comes from road traffic accidents, the head injuries, where we find they had patient going into reversible brain injury, and then the heart would be functional. So this is these are the important stakeholders: neurologists, neurosurgeon, intensivists, and these patients land up in these areas only. And these are the first frontline doctors who witness this patient is going into a brain death, and they should identify and they should declare the brain death. And that's where most of the state government have come up with a GO targeting this section of the the stakeholders. The second is the hospitals. The hospital, including whether it's a private hospital, it's a public hospital, the hospital should be geared up. So even though the neurologist is there, is willing to come forward and declare the brain death, the whole system, the hospital should be should be on toes to get into all the logistics, the OTs, the organ retrieval, the coordinating with the recipient teams, the whole, once the donor is active, I think then 50 to 100 people should be coming together to make these organ donations happen. So hospital should be geared up, irrespective whether it's a government or public hospital. So we need to sensitize the hospital. The next stakeholder is the police or the forensic. So as I said, most of the donations come from the road traffic accident. I don't know what is the procedure in Africa, but in India, whenever there's the road traffic accident, it goes into a medical legal case. So when there's a medical legal case, it has to be cleared by the police, and the inquest has to be done, and they should give a police clearance. And once the death occurs, it goes to the forensic department for the postmortem. So these two department coordination, cooperation will always be there for a better program. The next is the organ allocation. As I said, there is a huge gap between the organ requirement and organ availability. So there should be a very the optimal usage and equitable distribution of these organs across the entire population. So you should have your own allocation policies. And it all depends upon how you evolve your program. We have so many successful programs available. In fact, our allocation policy, we have tried to adapt it from the Western, and we have tried to change that to suit to our population. So we can take the existing models in the world, particularly from the West, the American and the European societies, and you can have your own group, and then you can discuss and can evolve your own allocation policy, which is equitable and optimal. The next is the public participation. So public is important because donations, when this donation is happening, it's very important to have a consent from the family member. Here again, there are different policies. So Europe, as I said, there is a very huge donation rate of 50 per million population. There the policies opt. You should also know about the opt out and opt in. So opt out is by default, any of the citizen is an organ donor. Whenever we find a patient is a brain dead, we don't have to go to the family members and seek permission on the consent. It becomes a property of that particular state or that particular the country. And as per the policy of that particular country, organs are being allocated. So that's it's called opt-out system. So by default, every citizen is an organ donor. And if he wish not to donate organ, he has to opt out of the system. So these are there in only few of the European countries where the maximum organ donation rate is same. But most of the countries opt in, including India, where we need to take the consent from the family members. And the next stakeholder, important key person in the entire program is the transplant coordinator. So again, it depends upon the policy of the country, because country to country it varies in the places where there's opt out. So basically their main role is the coordinating the family members, giving them the support and empathizing them, and then, easing out the entire process of organ donation and transplantation. And other important challenge, particularly in our country like ours, is the counseling the family member for donation, because ours is an opt-in. So major responsibility is the convincing the family members in the period of grief when they have lost their loved ones, and then trying to convince the family members for the organ donations, giving them the bad news that their loved ones is no more, and the next challenge is to convince them for the organ donation. So these are the important points where you should emphasize, and you should have your own teams working on these particular areas and evolving your own, identifying your own challenges and coming out with the solutions for these challenges. So I think if you work on these lines, you can have a successful program in your country as well. So how we have evolved our own program in our state. So as I said, we have the act available, we have the rules available, as which as a state we should follow whatever is the act and the rules have been released by the country. So we have developed our own, come out with our own GO, that is the government orders. So it has come up in 2010. This is called as a Jeevan Dan. So Jeevan Dan literally means donating life. So our government in 2010 has come up with a GO. So again, it is in sync with the act and the rules. So I'm not going to the details of all these things, but just emphasize that there are two major committees in that. One committee is called as a Cadaver Transplantation Advisory Committee. The chairperson is the secretary of the Health Department, Health and Family Welfare Department. And the convener is the director of our own hospital, the Nizam Institute of Medical Sciences, NIMS is the convener. And the members are the directors, the superintendent of the various major public hospital in the state. So this committee is called as an advisory committee, and they sit and they form the policies. So what I suggest is you can have committees for various, the components which I have discussed earlier. These scientific committee can recommend to the advisory committee, and advisory committee will come up with the policies in all the areas. And next committee is the appropriate authority of cadaver transplantation, where the director of medical education is the chairman, director of the NIMS, our institute is a co-chairman, and I being the chief transplant coordinator. This committee look at the day-to-day functioning of the program. So you should also come up with certain two committees. One is the Apex committee, which would form the policies, and the second committee would look into the day-to-day activities, and the scientific committees, which will evolve the various scientific guidelines, including the organ allocation policies or whatever it is. So then we have a subcommittees. Subcommittees again we have as per the organ, because organ allocation policies are different for the different organs. So we have subcommittees for the liver and pancreas, subcommittees for heart and lungs, subcommittees for kidney and other organs. So these are the committee members. So with this background, in 2012, it's been 10 years now, 2012 June, we have opened our office, Jeevan office at our own institute, that is NIMS NIMS Hospital. So we have a framework of the flow. One, we have a chief administrative officer, and then under the administrative officer, we have the administrative staff, and we have 4 major wings. One is the basically this wing which deals with the software part, the organ allocations, having the developing the software for the organ allocation, and amending as per the recommendations recommended by the scientific committee, the organ specific committees or the subcommittees. The second would be addressing the public education programs and public awareness programs. This is a continuous process, because as we all know, there's a lot of resistance in the public, and then they come up with a various the public what do you call awareness programs, and they reach out to the general society, and they conduct various programs to bring the awareness among the public. The third being the counselors. So we have a group of counselors in this, and they go to the family members whenever we find a organ potential donor in the hospitals, and they are trained, and they try to counsel the family members. And the fourth wing is the training of the medical professionals, because when we need to train, we need to have a manpower who are expert in organ transplantations, organ retrieval, and then transplantation. So we have the team which would actually train the doctors or train the medical professional in terms of the declaration, donor declaration, in terms of optimizing the the potential donor, in terms of retrieving the organs, and then transplantation as well. So these are the 4 major departments being run in our the program. So the training areas of training are the first and foremost. The thing is the brain death declaration. So unless we identify a donor when the brain death, unless we try to declare the brain death as per the legalities, as per the whatever is the rule in your country, so we can't have a donor. So the first thing is you have to train people for the brain death. So again, as I was discussing with Dr. Lloyd, that it's again, each of these is again can be a CME or can be as a webinar. So we can have the neurologist or the neurosurgeon, the expert or intensivist talking about this. But briefly, I just want to tell, the brain death declaration is the most important part. We have to identify the patients who have gone into irreversible coma, and should look at the brainstem reflex. This is a complete cessation of the brainstem function. So look at the brainstem reflexes. And the test for the confirmation of the brain death is the apnea test. It's a basic clinical test where you're trying to identify that there is, usually you're trying to stimulate the brainstem and see that whether it's functioning or not. And it is done by, disconnecting the ventilator and building up the PCO2 to, from the baseline to above more than 20 millimeters of mercury. So with this, they are trying to, stimulate the brainstem for the respiratory. There are no respiratory efforts despite increase in the PCO2, which you see by subsequent ABGs. So that is what is called as a apnea test. So I think when our GO has defined, this is in sync with, of course, with the Act. So you can also re-emphasize how to declare the brain death. So one of the brain death committee can sit and come up with the procedures how to do the brain death declaration, and then how to document it legally. So this can be developed and then implemented at your country. So this is the apnea test, is the clinical test, but however, in some situations, certain situations where we cannot perform the apnea test, particularly in case of chest injuries, or in case where once when the ventilator is disconnected, patient goes into the hypotension or the cardiac arrest, we can go for the ancillary tests. Ancillary tests are, for example, the cerebral angiography, where we demonstrate with the help of angiogram, cerebral angiogram, there is no perfusion of the brain, or by the help of EEG, there is no electrical activity of the brain, or by perfusion scan, where we can demonstrate there is no perfusion. That is called as an empty skull sign. So these are the few ancillary tests which can be used only when there is no, it cannot be demonstrated by the apnea test. But again, each of the country have their own policies. If you go to Europe, they have one of the clinical tests with one ancillary test. So basically, you need to work on what is your definition of a brain death and how you can implement about it. That again has to be recommended by your own, the expert committee consisting of the neurologists and the neurosurgeons. And this is the form. As I said, the Act has several forms. This is the Form 8, which is about how to declare a brain death legally. And once the patient, the declaration team does the brainstem reflexes and then the team panel does the apnea test, and then there's a positive sign, there is no respiratory movements despite disconnecting the ventilator and increasing the PSOT by 23 baseline. So then they go into documentation of the brain death. As I said, there are 4 doctors need to sign. One is the medical administrator, second is the authorized specialist of the hospital, third is the neurologist or neurosurgeon, and the fourth is the treating doctor. So here again, I would like to emphasize that the apnea test has to be done twice. And again, this depends upon the age of the patient. So usually it has to be done 6 hours apart. 6 hours apart to ensure that there is no reversibility. But again, it is beyond 18 years when patient is adult, so 6 years would be fine. But if it is below 18 years, again, the duration increases. It is approximately 12 hours. And if a patient is in a newborn or infant, it is 24 hours. So again, duration of the 2 apnea test, it increases with decreasing age. The second challenge would be optimizing the brain dead individual or the potential donor. As I said, it's a dynamic process, and there is a release of catecholamine storm, and there's a hormonal deficiency, and then the cerebral systemic inflammation, which ultimately leads to the hemodynamic instability and metabolic failure, which has a deleterious effect on the potential organ donor and can damage the organ. So it is very, very difficult to optimize, and there's some rule of 100. There should be 100 per minute. The saturation should be 100. The blood sugar should be around 100, and the mean arterial pressure should be 100. This is a rule of 100 which you need to follow. I think again this can be discussed as a one of the webinars with the expert neural intensivist in optimizing the. I'm just trying to give the overview and what are the challenges. And most of the organs which can be retrieved are the heart, lungs, liver, kidney, pancreas, and the other tissues which can be retrieved are the cornea, the heart valves, the bones, the tissues, the vascular grafts, the blood vessels, and the skin. So with us, we are trying to only retrieve the major organs like the heart, lung, liver, and the kidney. And only few situations we have used the pancreas, and recently we have started the skin banking. Again, the retrieval is again, it's a difficult task. It's a complex task, and people have to be trained in that how to retrieve the organs without damaging the other organs, and particularly when there's a multi-organ transplant. You can start with the kidney retrieval or the kidney donation alone to begin with, and gradually when you improve your program, you can go with the multi-organ harvesting. And again, there need to be coordination among the different teams, particularly when we have the heart and lung being used, the liver being used, and kidney being used. We should see that when the heart and lung are being retrieved, the kidneys are not damaged. They have to, because there is a concept called warm ischemic time and cold ischemic time. So and it is not taken care when the heart is being retrieved and the kidneys are not being taken care. The kidneys are, they get necrotic, and they cannot be used for the organ transplantation. So hence it's very important for the coordination between the various teams, particularly with respect to multi-organ retrieval program is going on. So it's always better to start with kidneys, where we have very good cold ischemic time, very long prolonged cold ischemic time, and then gradually increase to include the liver. And subsequently, you can go on to expand your donation program to have the heart and lung transplantation as well. Again, packing, there are static way of packing and a dynamic way of packing. Again, it requires, I think there is a lot of literature evolving. It again requires detailed discussion. I'm not going to go into this, but however, I have to emphasize that there is definitely the packing also we need to be properly packed and labeled so that it's not misplaced and you're not changing, the organs. So it has to properly labeled and then, packed. And the next part of the program, which is very important, is the organ allocation. It has to be equitable and the optimal. Now, every individual should be able to access the organ transplantation. And it is not in this process, it should not be like, the elderly patient has taken the organs very, very young. Elderly who is frail and his life expectancy is very little, and he has received the organ and has actually wasted the organ. So in that process, it should be very optimal utilization where the graft survival is better with whatever organ they have transplanted. So we are able to balance the equitability with the optimal usage of the organ, and we should be able to reduce the discard rates. And it has been shown that even in the United States, in the one of the evolved program, the discard rate is as high as the 20 to 30%. So we have a very unique program, unique organ allocation protocol, which is online. So this is our website, jeevandan.gov.in. We can just go through this website. This is our dashboard. So we have all the details of patient registration is online. The donor has to be registered online, and we have a criteria for organ allocation, which is inbuilt in the system. So we have a score system for the kidney. So it depends on the wait list on the the system, the duration, vintage of dialysis, the previous the fistula failures, and patient if you had a previous graft, if the primary graft failure is there, he get an extra score. And of course we have an age match criteria as well. So if a donor is like 50 plus or minus 10, will get an extra score, and the younger individual, they have an extra score because their the survival rates are better, and their particularly organ acceptance and survival would be better. So children are given the more score. And of course, if patient is a previous donor, he happened to donate kidney to his own kith and kins, they'll get an extra score. So we have a score system for that, and we get a cumulative score. So I don't know whether you're able to appreciate. So this is the wait list of the patients. The wait list one has a score of 7.6. So unfortunately, we have not included the HLA matching or the the sensitization as in our program, because though I can say that ours is one of the best model, we are not evolved to that stage where we can include the HLA matching, because donor we are not able to get this HLA matching as of now, HLA typing as of now. So we are not gone, but subsequently in future probably we may include these as in our allocation system. So again, we have two kidneys. One goes to the the in-house, and the second kidney we allocate as per the common pool, where all the hospitals will come into the waiting list. So this is how we get a score. You can see this is the wait list number 1 patient has a score of 14. So this is the combined of waiting list for all the hospital where the common pool kidney is allocated. So again, the liver, we have this MEL score. Basing on the MEL score, we get a wait list. And as you all know, MEL score depends upon the bilirubin, the creatinine and INR. And again, it has to be updated every 3 months. And we have good number of the hospital where the liver transplantation is being done. So, and we have a unique rota system where one hospital gets in rotation, one hospital, after that another hospital. So we get the liver, particularly when the organ is coming from what we call as the non-transplant centers. We have transplantation centers, we have non-transplant centers. When organ is coming for transplantation centers, anyhow the organ goes to that particular hospital as per the MEL score. When the organ is coming from a center where there is no transplantation the program available, it goes to a common pool, and these organs are allocated as per the rota system. And this rota system is randomly being given. So we also have this what is called a super urgent. In certain scenario, the organ has to be allocated, the patient required transplanted within the 24 hours. So we do have this super urgent liver criteria, and we have a unique the criteria for that, super urgent criteria, particularly patients who have this the acute fulminant liver failure because of paracetamol poisoning, or because of the infections like hepatitis A and hepatitis B, or idiosyncratic drug reactions, or patients with Wilson's disease or Budd-Chiari syndrome, or hepatic artery thrombosis after liver transplantation. Within the first week, if it goes into a hepatic artery thrombosis, he becomes eligible for the super urgent liver, and early graft dysfunction within 1 week of liver transplantation. So these are the patients who fits into the category of super urgent liver transplantations. And we do have a priority for the multi-organ transplantation, particularly with liver, kidney, heart, heart and kidney, and then the heart and lungs. So we have priority for the multi-organ before we give it to individual organs. So everything is like the online, the donor have to be, the details have to be entered. Once we enter the donor details, automatically, as per whatever the allocation criteria have been recommended, so even the system itself will pick up the recipients, and that's how the organ allocation is purely online, and it is very transparent. So we have around 32 hospitals registered in our program for organ transplantation as an organ transplant centers. And among them, 4 hospitals are from the government public sector. So this program was started in 2013. It's been a decade now. As you can see, there has been a gradual increase in number of donations. And this year already we have 153 donations. So overall, we have around 1,100 donations over the past 10 years. So this is the donations, and then you can see 1,121 brain dead donations have happened, and 1,683 kidney transplantations have happened, 1,036 liver transplantations, 158 heart transplantations, and lung transplantations 183, and overall 4,000 plus organs and tissue transplantations have happened by brain dead individuals. So this is what is the chart showing, graph showing the donations. As you can see there, it's not uniform all across the entire state. There are 10 hospitals where constantly the donations are happening. So we need to work on the other hospital as well to increase our donation rate. And in contrast to the live donation, so there's a lot of further disparity in organ transplant. The gender disparity in organ transplant is being talked about, where the females are the donors and the recipients are the male. So in the disease donation program, we see the males are 78% in contrast to a female, where it's only 22%. But again, it can be biased because only males are brought to the for the medical care, and it's the male who are who are actually traveling and they meet with the road traffic accident. So it can be a bias also, but it is good to hear that males are more donor than the females, in contrast to unlike that of a live donation program. So if you look at the individual organ donations, as I said, around 3,000 plus organ transplantations have happened. If you look at the blue bars are the kidney, there has been a gradual increase in the kidney transplantation rate. But of course, 2020, there was a fall because of the COVID, and we have actually, came back, bounced back with around 228 transplantation 2021 and 203 transplantation 2022. And so also was the liver transplantation. So there was a small dip in 2020 because of the COVID, and subsequently we have regained the even liver transplantation. I would like you to concentrate on the violet chart, violet bars, which is actually a lung transplant. As you can see, there was hardly any lung transplantation happening before COVID. If you can see, only after 2020, the lung transplantation has improved. This is because of the COVID, where more patients were registered for lung transplantations because of the lung being involved because of the COVID. So that's how COVID has affected our program, improving the lung transplantation rates. This is the number of patients being registered with us. So as on today, we have around 8,331 patients being registered for various organs. If you can see, there are only around 6 to 7 hospitals which are actively doing organ transplantation. Maximum number of the recipients are being registered. So we belong to the first bar, that is the NIMS hospital, where we have 1,348 patients being registered for various organs. So public sector, there was one, the challenge which you face is only the private sectors are doing well in organ transplantation. The public sectors, even the poor, they don't have accessibility to organ transplantation. So, but in contrast, you look at the performance of the public hospital. We come from a NIMS hospital, as you can see, we have done 343 the cadaveric transplantations. So we do both the deceased donor transplantation as well as the live. So over the past 15 years, we have done around 1,500 transplantations, and out of which I can say around 20 to 30% are from the deceased donor. In fact, last 5 years, look at it is 50-50%. 50% is coming from a deceased donor and 50% is coming from the live donation. So then our public sector is not lagging behind. It is accessible. The organ transplantation program is accessible to the poor people. And all these transplantations are happening under the insurance coverage by the government. And this is where our insurance policy is called Arogyashree. It is being provided by the government of Telengana. And all the poor, the organ transplantation is happening free of cost, and they have a package which is being provided to the hospital, and the patient did not pay anything from his pocket. So these are the different packages for the different organ transplantation. I said the transplant coordinator are one of the key person in the entire program, because these are the people who take care of all the processes of organ transplant, right from the counseling the family members, and then making them comfort, empathizing them, and then trying to coordinate with the neurologist and neurosurgeons for the brain declaration, trying to coordinate with the optimizing team, the team of nursing doctors who are trying to maintain the donor for better optimization, and trying to coordinate with the organization, the Jeevan Dan, for the organ allocation, and trying to coordinate with the recipient hospitals, trying to fix the talk to the OT room, and then trying to fix the time, and trying to coordinate with all the different retrieval team for the retrieval. And once the organ retrieval is done, and packing the body and giving back the body to the family members, the entire process is done by the coordinator. Coordinator is the forefront of this whole program. So it is very important that they are trained in every aspect of this organ donation program. So we do our organ coordinator training program as well. So we have trained about 400 people so far, and we have this yearly program. This is the brochure available. So we do have what do you call these the syllabus for the coordinator training program. So we don't have such a program anywhere in the country, particularly with any of the universities. So we don't have structured program. So we have designed this program. This book is also available in our website. We can just go through this website, jeevandan.gov.in. So we have covered all the aspects of this the organ transplantation. So you can just go through if you are interested, and you can download that also. So this is our team, the latest the coordinator training program. The team member who have been trained in this aspect. And end of the program, we give them the certificates also. And there were a lot of religious, because India is a country of secularism. So we have a lot of religions, and there's each religions have their own beliefs. And particularly with the Muslim community, there are a lot of resistance. So we try to go to the research scholars, the religious scholars, and then try to convince them through their own Bibles or Quran or Bhagavad Gita that our nature had never said against organ donation. In fact, all the religious, they talk in favor of the organ transplantation. We're trying to convince them, and we try to mobilize the religious scholars and try to reach the public. And after that, we can see there is increase in the donation rate. And this is the police. The police persons are also very, very important. As I said, most of the donations come from the medico-legal cases. So you should also concentrate in sensitize the police with respect to medico-legal cases. And they also help us in the trying to counsel the family members, or trying to create the green corridors. This is one of the training program for the police personnel in various aspects of the organ transplantation. What is their role? What is the role of the police in the entire program? So we try to try to train them, and we have also tried to have meetings with the higher officials and come up with the policies, like the practical the challenge I will tell you, because accidents happen somewhere very far away, and the donations happening in even hospital, and there's a system called as a first FIR, first investigational the report. So these accidents are registered in the nearest police station, and where the donations happening in somewhere far away hospital, which doesn't come under the jurisdiction of that particular police station. There is always a miscommunication gap. So we have tried to bridge the gap and ask the police to come up with the policies where, irrespective of the place of the accident or irrespective of the FIR registrations, anybody can come and clear the police, whatever is procedure from the police, or called investigation, or and then get clearance from the police, and so that we can go ahead with the organ donation easily. So I think you also should have a close association, close talks with the police people, so that they can help you out in getting these challenges cleared. So, and they also help us in creating a green channel. So as you all know, particularly in Hyderabad, in major cities in India, so it's like the traffic is a major problem, and the time of the cold ischemic time is very important, and organ transplantation is very important from one part of the state to the other part. So with their police also help us in creating a green channel and taking the organs in appropriate time. And now we have the concept of airlifting these organs, and now the latest we are trying to through what do you call And the airlifting is one of the the latest development in organ transportation. So this is what the police has helped us, and then we also attend their funerals, and then they also try to attend to their rituals. So each of the state or each other, I believe you also have some rituals that one person dies, and then we have on the 11th day, on the 13th day, some the functions or rituals being organized at home. So we go and try to attend those functions also, try to have a confidence of the family and try to appreciate them, try to acknowledge their their acts, and also try to pass on the message to the people, to the friends or the family members, so that they have done a very great job. So we make them hero in the presence of their own family members, so that the message percolates to the in the remote areas, and the people come forward for organ donation. So this is what we do, and this is one of the condolence program. We are doing that in their own place, in the presence of their own family members. That is the important factor in creating an awareness, particularly in the public, when you have a lot of resistance from the public. So basically they have apprehension. I'm sure you also might face this, that they are afraid that if we donate the organs, their own people, their own relatives, their own villagers will think something negative about them, and they have sold their organs, something like that. So this gives a lot of confidence among the public, and that's how people are coming forward for organ donations. So we also, another a lot of the controversies, a lot of the international regulations of whether to give monetary benefits to the donor family. So as of now, we are not giving any monetary benefits, but only we try to honor them in front of the public every year. And then I don't know, like in a lot of discussions going on in our country also, then what way we can help, whether we can help in other ways, like providing the education, providing the some assistance to the family members, particularly when they come forward for the organ donations. So as of now, we are just honoring them. And this is like programs. As I said, it's very important for to train the medical professionals, themselves, for what is brain death. Like most of the people, most of the particularly young generations, they don't know about the brain death. What is brain death? How to declare a brain death? What are the legalities? So we'll try to impart that knowledge through various CME programs across the entire state. So we have, as I said, we have recently opened even the skin banking. We're trying to use the tissues as well from the brain dead individuals. And so we do a lot of public awareness education programs through various we go to every event, every possible event, and then we have tried to mobilize the celebrities. These are all celebrities, these are all movie actors. So once they give the message, it directly goes into the public, and they get inspired. So we have tried to mobilize a few of the celebrities across our state, and he is one of the big celebrities in our state, is considered to be the #1 hero. So we have tried to mobilize the celebrities in creating an awareness programs. And these are the few, the public events where we try to, have some awareness stalls, so that people come around and they talk about organ donation. Somehow we try to spread the message across the entire state. And we do, organize various runs in various occasions. This was World Kidney Day. We have organized one, walk or run. So this is awareness drive, which we have organized recently on the occasion of World Kidney Day. So, and of course, was the media. The role is also very important. We should be a little careful with the media, because these are double-edged sword. So they can be some negative stories in the media as well. So you have to handle the media very carefully. So far so good. The media have been very helpful in creating a positive, awareness in the public. So whenever donations happening, we try to cover it in the media so that it percolates into the society. So we got a best award for the the software. So very transparent and equitable distribution, which is unbiased. We got twice the award from the government for a very sophisticated software for this, and we have got the award from the national organization also called NOTO for one of the best performing state in terms of disease organ transplantation program. This again I want to emphasize. So again, like it is for the awareness in the coming generation, next generation. It is very important that it should go into the textbooks. So it is there in our 10th class biology textbook. And there's a chapter which talks about the organ transplantation. It also talks about the disease donation. It also talks about the brain death and kidney transplantations. So if we can get into the textbooks, I think next generation will all know about the organ transplantation. Easier for you to sensitize and to prepare the next generation for the organ transplantation. And I think this, you should also work in terms of introducing this into your syllabus in the undergraduation or the secondary school. So as of now, so there is a chapter in the secondary school level. So these are the few clippings by the media, so where they have emphasized and they have actually acknowledged Telengana, our state, being in the top in the country for the organ transplantations. In fact, sometimes a few years before, it was Tamil Nadu, the other state which was doing well. So we have also surpassed Tamil Nadu in terms of organ donation. So I think this is the latest development, is the successful kidney transplantation from a genetically engineered pig to a human being, to actually a brain dead individual they have transplanted, and looked at the immediate graft function, which was very successful. And this is the heart transplantation from a genetically engineered pig heart to a human beings. In fact, a human being, in fact, it lasted for 2 months, and subsequently he died of probable CNV infection. So I don't know if you have time, I'll just quickly go through how the COVID has impacted our lives and our disease donor transplantation program. I'll just quickly go through. So I think, as with other organization, even the disease donor transplantation program in our state came to a halt for a few months, but subsequently we picked up. So, I just want to emphasize that the COVID transplantation, or the lung transplantation, has improved in last 2 months, because we saw most of the patients being suffered from the lung failure. They were put on ECMO, and then our lung transplantation program has improved last 2 years. From the beginning till 2020, there were only 20 transplants. Subsequently, we had 100 lung transplant being happening in last 2 years. So we are slowly trying to go into the peripheries by having zonal chapters. We have the central nodal office at the state headquarters, and slowly we are going to district levels through the what you call the zonal centers. We identified few important people and trying to percolate to the peripheries as well. And at a higher level, we are trying to connect ourselves to the national organization called NOTO. So we are trying to connect, they bridge the gap between a central to a state to a district level. So slowly we are trying to expand our program. So this is what I wanted to say about our disease donor transplantation program, and thank you very much. And we are available on the social media, so you can just follow us in all the social media. So thank you very much for the patient hearing, and I would love to answer any of your queries, and I'm happy to help you out in establishing your own program. So if you have I was just talking to Dr. Lloyd before we started this program, that it requires a lot of session, particularly focusing on each and every aspect. The declaration of brain death, the legalities of brain death, the optimizing of brain death, the allocation of the policies. So all these things, and then sitting with your own, having your own, what do you call, the police, involving the police and the forensic people, sensitizing them, and sensitize the public, and the coordinators, how to train the coordinators, identifying the handpicked people who are passionate about working as the coordinators and training them. So these are various aspects they have to focus on, and I think it's not difficult. So if you all come together and work together, definitely you can come up with a very beautiful and nice successful program, which is more successful than us. Thank you. Thank you very much.
Thank you so much, Professor Swarnalatha. I think, you deserve accolades and congratulations for the wonderful work you're doing, and for the national awards that you've rightly achieved. I would just want to say that we're very grateful to you for giving us your time today. And we do look forward to collaborating with you on many more such forums. And it was an honor to have you for our 100th Fireside chat. So that made it even more special. And thank you once again on behalf of the entire AHN team for giving us your time.
Yeah, thank you. But I see if you have the question in the chat box. If I'm allowed, I'll take up those questions.
Yes.
Sure,
Sure, in the chat box.
Yeah. So I see Dr. Ahmad asked, are there scenarios that the recipient can receive both cadaveric kidney? Yeah, it does exist. Like particularly, we have a standard criteria and external criteria. Standard criteria like, young patients without any comorbidities, they have very good urine output, hemodynamics are good and creatinine is normal, organ functions are normal. So usually we go with a single kidney. But on the other hand, we have the external criteria donor, like elderly donor, diabetic, more than 55 plus, and then hypertension, his creatinine is more than 5. So we can actually have, in circumstances, we can what is called as a peri-implantation biopsy. We can go for a peri-implantation biopsy. We can look at the quality, and then if there is, the chronicity or if more than 20%, we can go for the dual kidney transplant. It's called as a dual kidney transplant. Both kidneys goes into a single recipient. At the same time, we have, the young donors. As I said, we do have a young donors, like, the youngest being the 4 years old. The 4 years old kidney would be very small. And then we can't have that small kidney going to an adult. So what we do is we take out both kidneys and block. So in fact, they are taken with, the inferior vena cava and then the aorta. And this aorta is attached, not the individual, the kidney and then, renal artery, but the aorta and the inferior vena cava is, anastomosed to the recipient as an en bloc. So we do, we had certain situations doing a dual kidney transplant in recipients. I can remember it's around 2 to 3%, not much the percentage, but it did happen in our system. So the second question, Dr. Lloyd is from Dr. Lloyd is, what are the common multi-organ transplant that occur in India? Okay, so multi-organ as of now is the liver, kidney. So these are our major. We have certain situations like hepatitis B. Then we have a liver transplantation, the kidney also being affected, or we have patients with the cirrhosis. Because of subsequently they go into the renal syndrome, and then which is irreversible kidney damage. Initially they register as a liver transplant, subsequently they go on to develop the kidney failure, and then they register as a multi-organ transplant recipient. So it's not much more than 5%. I think it's only around 5% the multi-organ transplantation. And second is we have few situations of simultaneous kidney pancreas transplantation. So in a patient with type 1 diabetes, we had simultaneous kidney pancreas transplantations, and we did had the combined heart and lung transplants, and patients particularly with heart and lung failure, with high heart failure with high pulmonary pressure and lung damage. We also had this combined heart and lung transplants. That was the combined organ transplants. And Dr. Lloyd again had a question of what is green corridor? Yeah, green corridor. As I said, there's a traffic in a modern, now the present days, the traffic is a major issue in most of the cities, particularly the advanced cities. So in India, particularly the Hyderabad, Bangalore, I think Dr. Lloyd, you are from Bangalore. You can see, we can know, how bad is the traffic in Bangalore. So, and the time is very important when you're transporting organ from one part of the city to the other part. So if you're stuck in traffic, it takes, few hours. And particularly in the organs like the heart and the lung and the liver, where the cold ischemic time is only 5 to 6 hours. So we should see that these organs are transported to the recipient hospital, and then it is transported. The whole thing is, the clamp time and clamp release time. So the time is very important. As the clock starts clicking, so I think it is very important to have the account of the time which is clicking, and then. So we try to create a green corridor. Means police helps us in clearing the traffic. We have to just as simple. We have to call a control room. Control they'll ask for the details like when it is starting, at what time it is starting, and what is the route, and which is the vehicle carrying this. So they'll see that the whole of the traffic is cleared. At every junction, not even the ambulance doesn't have to wait even for a minute. So usually, whatever the time it is taken in a routine traffic, it is 2 to 3 hours. It will be delivered, transported within 10 to 20 minutes. So that's how it's a green corridor. It's called. And in fact, when I was talking to the police people, they said green corridor is created for only 4 people in the entire country. One is the president, the prime minister at a national level. At state level, it is the chief minister and the governor. So these are only 4 people who get this privilege of having a green corridor. And beyond these 4 people, it is only the organs. That is the importance of organ. So that is the green corridor. And okay, so I hope I have answered your queries. Next is like question. I think I have done all my questions. If there are any more questions, I am ready to answer.
Yeah, I think no, I think Swarnalatha, you've got phenomenal amount of experience, and congratulations that in a country like India today you're leading the organ donation program in terms of number of the donations and conversions to transplantation.
Yes.
This is very phenomenal actually, and you're beating Tamil Nadu too. That is great news, and I never knew that. Wonderful,
Yes,
congratulations.
Tamil Nadu almost 2018 itself, sir. 2018.
Wow.
And believe me, it was not an easy journey. But then, having said that, if you are passionate, the most difficult task is getting people together on board, and particularly for neurological colleagues in declaring a brain death and intensivists. And if you can put your intensivities in the forefront, I think that 50% of job is done, because they can declare brain death, they can optimize better. And if you empower these people, if your intensivities group is strong and you have very good coordinator, I think half of your job is done.
Wonderful, wonderful. I think I will arrange some meetings between certain interested groups who are very keen on cadaver transplants. If you can then advise on how to go on, a lot of these things that you just mentioned, a whole lot of them with the brain stem, the allocation, then apnea testing, and all these things. It will be very nice with all the experience that you've actually outlined in situations where apnea test cannot be applied, and so many very important aspects. And I think today was actually a discussion. I think tomorrow morning the discussion on cadaver transplant, and there was a Spanish group who was there today. I met them this morning. They know you as well from Spain. Shui, Brian, and Shui. I don't.
Actually, we have been coordinating with even the Spain people. So we have tried to, as I said, we have the training program. So we have taken their help in establishing our training programs, the medical practitioners and transplant coordinators.
Yeah, so that's another thing. Transplant coordination. That's another very important issue. So I think I will shortly reach out and would need your help, and we just have a webinar and then take it from there, and then they would actually be able to get your expertise on this wonderful work.
Thank you very much, sir. But thank you for the opportunity bidding. I am always will be happy to support you, you guys.
Thank you very, very much, Dr. Swarnalatha. Thank you very much. You were very late there as well. Extremely grateful in keeping up so late.